Good evening, everyone. My name is Nicole Milano, and I want to thank you all for joining us for the first Heberden Society lecture this academic year with Dr. Janet Golden. I do want to mention that closed captioning is currently enabled if you have the updated version of Zoom. You can find that option at the bottom of your screen to turn off the captioning or turn on the captioning during tonight's lecture. If there are any attendees with visual impairments, please let us know in the Q&A box that can be found at the bottom of your screen, and Dr. Golden will be sure to describe the visual components of her slides in more detail as she moves through the presentation. Now, on that note, I also want to mention that we do invite participation in our question and answer session following today's talk, and you can drop your questions into that Q&A box at any point during the lecture tonight. Now, I do have a few announcements to make before our lecture begins. The first is that I want to invite you to join us for the 3 upcoming Heberden Society lectures. On January 18th, Carnegie Fellow Dr. Wangwei Mugai will be discussing infant mortality, race, and the American roots of a health inequality. On March 2nd, Dr. Naomi Rogers will present on health activism and community control in American medicine in the 1960s and 70s. And then finally, join us on April 26th as Dr. Jaipreet Virdi highlights content from her award-winning book, Hearing Happiness, Deafness Cures in History. I will be sending out more information about these lectures following tonight's presentation. Now, for those who are interested in the history of the New York Presbyterian Weill Cornell Medical Center, I would invite you to explore the website for our very own Medical Center archives. The archives includes materials dating all the way back to 1771, including this program from symposia on syphilis, cardiac conditions, and diseases of the joints and tuberculosis, coordinated by Cornell University Medical College, now of course known as Weill Cornell Medicine, in 1916. More than 14,000 photographs and documents from our collections are digitized and available for reference through the links seen here. Now, I'm thrilled to introduce our speaker, Dr. Janet Golden. Dr. Golden is Professor Emerita in the Department of History at Rutgers University in Camden, New Jersey, where she specialized in the history of medicine, history of childhood, women's history, and American social history. She is the author or editor of 10 books, including Babies Made Us Modern, How Infants Brought Americans into the 20th Century, published by Cambridge University Press in 2018, and The Making of Fetal Alcohol Syndrome, published by Harvard University Press in 2006. Dr. Golden also co-edits the Critical Issues in Health and Medicine series at Rutgers University. Her work has been supported by the National Institutes of Health, the National Endowment for the Humanities, the Commonwealth Fund, and the American College of Obstetricians and Gynecologists, among many others. Now tonight, Dr. Golden will explore the patient experience of syphilis thanks to a vast collection of patient records from the Philadelphia Orthopedic Hospital and Infirmary for Nervous Diseases and the Hospital of the University of Pennsylvania, and how new diagnostic tools, treatments, and knowledge impacted the patients' lives in the late 19th and early 20th centuries. I'm always happy to give the virtual stage to someone who utilizes archival resources so effectively. Welcome, Dr. Golden.
Thank you very much, Nicole. Thank you to everyone who's here tonight. I'm sorry I can't be with you, but you're probably very glad I'm not with you since I'm still testing positive with my rebound COVID. And we can discuss that as a grand rounds after I answer your questions tonight. So let me begin by saying, meet Mr. Smith. And all the names I'm using tonight are anonymized. He was an unmarried, 32-year-old Irish immigrant employed as a clerk when he came to the neurology dispensary of the Hospital of the University of Pennsylvania, which I'll call HUP. He arrived in 1883 seeking treatment for depression and general nervousness. He believed his problems resulted from overwork. 2 years later, he returned and received a diagnosis of locomotor ataxia. Next image. This is a form of late-stage syphilis with degeneration of nerve cells, now often called tabes dorsalis. Between visits, Mr. Smith began experiencing a feeling of constriction around his abdomen, pains in his legs. He had trouble buttoning his clothes. His pupils did not contract to light, what we call Argyll-Robinson pupil. And that was very common to neurosyphilis. His symptoms made the diagnosis easy. His acknowledgement of a chancre 12 years earlier was not a necessary piece of data, although it did confirm the doctor's judgment. Mr. Smith made at least 16 visits to the HUP dispensary over the next 3.5 years. The records are incomplete. At each visit, an assistant physician examined him and recorded notes prior to his seeing a senior clinician. Next image, please. During one visit, Horatio C. Wood, a clinical professor of neurology at the University of Pennsylvania Medical School and author of, I'm sure, a book you've read, Syphilis of the Nervous System, 1889, Dr. Wood examined him, as he did some other patients, sometimes overruling the assistant doctors, but he did not do so in this case. At the clinic, Mr. Smith received his prescriptions for the two standard medications, potassium iodide and mercury, of course, longstanding treatments for syphilis and ones that were heavily promoted by manufacturers. The potassium iodide gave Mr. Smith digestive problems, a side effect doctors recorded as iodism, and his dose was reduced. He then began a course of mercury by inunction. Next slide. And following that, you'll see the man with the chest pad there for to keep his inunction, his mercury on him, and use of something we know of today, Eucerin, which was also used for applying the mercury. Mr. Smith later received strychnine sulfate as a tonic, as well as medications to treat the side effects of the other remedies. Nothing in his background, his condition, or his treatment differentiated him from others seeking help for late-stage syphilis at HUP. Next image. He was, however, immortalized, and here he is, in a sequence of images taken by the photographer Edward Muybridge in 1885 as he worked with HUP clinician Francis X. Durkheim in a study of human locomotion. Next slide. The sequential photographs show him in a white shirt, naked below the waist, in order to display what was then called his ataxic gait. The disease and its manifestations are the sort of the subject of the image, and it's Mr. Smith's picture. We know his name, but I am not using it, are now on sale, as are those of other HUP patients. Next slide. And there he is again. Now, Mr. Smith was more than his diagnosis. We can probe his record and those of other patients with tertiary syphilis to get a different kind of picture, one of increasing impairment and of a life limited by a chronic, often worsening, painful condition. Individuals with late-stage syphilis experienced many and sometimes overlapping challenges: aching joints, leaking bladders, poorly functioning bowels, movement problems, vision and hearing loss, fatigue, mental confusion, and sometimes general paresis. While people with earlier stages of the disease could continue to work, people with physical indications such as rash, patchy hair loss, or open lesions could not hide their condition and might be restricted from public life and workplaces because of ugly laws or simply their appearance. Next image. This lets you know about ugly laws that kept people off the street. For social critics, syphilis was both a medical and an economic problem because it made people unfit for labor. For poor and working class individuals and their families, syphilis was a personal and a household problem, threatening their self-sufficiency as well as their health. Next image. What I want to do today is to show syphilis history in the years before effective treatments became available through the model of social disability rather than a medical model of disability. And what do I mean by this? Next slide. The medical model of disability will show disability disadvantage in terms of pathological states of the body and mind, and it regards people's limitations as resulting from bodily differences. The social model of disability explains disability in terms of the relation between an individual and her social environment. It looks at the exclusion of people with certain characteristics or impairments, and their exclusion from domains of social life. So there's deliberate segregation, but also in built environments and in organized social activities. So in attempting to excavate the lives of Mr. Smith and the other people I'll talk about, I want to center the patient experiences of illness in the history of medicine and in disability history. Finding sources to do that can be challenging, but in the end, whatever we uncover can contribute to each discipline and give new perspectives on the past. I use the patient's voices that appear in the records as best as I can, letting them speak for themselves, following the model of, quote, nothing about us without us, that came out of the HIV activist movement of the 1980s and is now central to so many movements, including disability studies. Next image. At the same time, I want to acknowledge the records were written by other people and for the purpose of treating a disease. So they are inadequate proxies for the thoughts and experiences of the individuals I'm going to talk about. Next slide. So first, I want to look at a little historiography and see where individuals with syphilis appeared in past studies. And this is going to be very quick. Social and cultural historians address syphilis in their studies on moral reformers, prostitution, sexual double standards, and eugenics. They did a very good job of tracing the attempts by some cultural and medical leaders to shift conversation from social purity to social hygiene. Next image. Despite this, substantial numbers of people still regarded, and medical and popular accounts as well, still regarded venereal disease, particularly among minority, immigrant, and working class men, as a signal of cultural depravity that could best be contained through ending prostitution and stopping the breeding of the unfit. Medical historians, by contrast, saw syphilis as a question of disease origins, transmission, diagnosis, and treatments, and how those changed over time. By the late 19th century, the period I'm talking about, physicians knew the multiple manifestations of syphilis and its sequence of stages, but they too saw syphilis through the lens of social class. Case reports referred to private patients by their occupations and nodded to those with upstanding characters by pointing to their diagnosis as uncharacteristic or placing its source outside of sexual transmission. Next slide. Writing about unusual methods of acquiring syphilis, that's a quote, one doctor admitted that less stigma attached to innocent individuals as opposed to people, quote, guilty of sexual transgressions. And here are some of the innocent sources of infection that were offered in the medical literature. You can just go ahead and read that for yourself. I would say don't base your practice on that chart. Even if innocently acquired, the diagnosis remains stigmatizing and disclosure a risk. Accusing someone of having syphilis was actionable under defamation law, as was true of leprosy and plague. Pension officials denying the claims of Civil War and Spanish-American War veterans who had venereal disease explained that their disabilities resulted from their own vicious habits. Next slide. Now, more recent medical history, of course, focuses on 20th century breakthroughs, the discovery of bacterial causes of syphilis, the development of the Wasserman and Noguchi diagnostic tests, and the creation of arsphenamine or salvarsan, or what we'll call 606, as an effective chemotherapeutic treatment. These scientific advances made a critical difference in the lives of individuals with primary and secondary syphilis able to receive full treatment. The application of new medical tests would lead to a decline in deaths, debility, congenital infections. But these lauded breakthroughs did little for people with late-stage disease. 606 could only arrest the progress of the disease. It could not undo the damage already done. So my point is that to shine a light on medical discoveries is to investigate science, medicine, knowledge, and progress. To study individuals unable to access or benefit from these findings leads into the shadows and to a story about disability, exclusion, pain, and death. Now, the history of public health is another narrative strand. The new diagnostic test made possible case tracing, followed by treatment, and it yielded epidemiological data. A lot of cities began mandating venereal disease reporting and premarital blood testing. Next slide. The premarital blood tests have only went away recently. About 8 to 10% of the population in the early 20th century was said to have syphilis, although rates were severely undercounted. Next slide. And certain populations, such as military recruits, had far higher rates. The military kept very good track of this. Federal law changed in 1917 to have federal controls on syphilis, so that's why I stopped my study there. Now, other levels of state government, city government did become involved in syphilis disease control. Federal immigration law classified syphilis as a loathsome disease, meaning automatic exclusion, although only people with signs of the illness were tested at ports of entry, and most were stopped before they got on ship, because otherwise the companies would have to pay to send them back. Now, I want to be clear that the new scientific findings did not overlay old biases. One physician argued for mandatory quarantine and treatment, fearful of, quote, the half-witted tramps, gang laborers, and foreigners, end quote, passing through the free clinics but failing to return for treatment. Working class women and men, and women especially if they were prostitutes, were viewed as the cause of their own misery, the source of infection for others, as non-compliant patients and morally compromised. Next slide. Social class biases shaped data collection policies and debates. New York City health official Herman Biggs pushed for case reporting by institutions, but exempted private physicians, perhaps believing they already had patients under their care. He assumed, quote, the poorer classes, quote, end quote, were unseen by private physicians, took treatment only to relieve symptoms, and then stopped treatment in order to earn a living. Other public health leaders dickered with Briggs's presumption and observed that private physicians often hesitated to report their patients' cases because of the shame of the diagnosis and their families finding out if case tracing was begun. They warned against Biggs of the need to be alert to, quote, the possibility of the occurrence of the disease in persons of the highest moral character. Now, what Biggs overlooked in criticizing the poorer classes was the fact that most dispensaries where working class patients got care had workaday hours, making it difficult for people to make regular medical visits. You'd have to miss work to return for prescriptions and follow-up week after week. Physical barriers may have limited care seeking. Locomotor ataxia, Mr. Smith's diagnosis, could make it difficult for patients to go up or down stairs in order to access a clinic. Blindness could prevent them from seeing their way to the clinic. So rather than asking why patients did not seek help, the interesting question is, why did some persist in visiting clinics? The records from HUP and from the Institute for Nervous Diseases of the Philadelphia Orthopedic Hospital, I'm going to call it the IND, show that while many people made only 1 or 2 clinic visits, a number came back numerous times over several years or for even over a decade. So let's return to Mr. Smith. Next slide. And to the HUP Neurology Dispensary. And to another group of patients that I'll get to later. I want to note that many clinics in Philadelphia many but not all clinics in Philadelphia treated patients with syphilis, but the records of the 2 institutions I'm looking at are the most detailed. I analyzed all the cases from each institution, starting when they first became available in 1876 until 1917, when venereal disease became a federal concern. Next slide. The HUP Neurology Dispensary, visited by Mr. Smith in 1875, was overseen by Charles K. Mills, who was in turn overseen by Dr. Wood. Their dispensary clinicians treated an average of 377 cases a year between 1875 and 1889, with the number increasing over time. Next slide. Syphilis cases, primarily individuals diagnosed with locomotor ataxia, were a small part of the patient load. And I want to note that paresis patients were seen as, in this era, patients with there were 3 diagnoses: syphilis, locomotor ataxia, and paresis. That's how the World War I records listed them and the U.S. Census listed them, but we now know they were one disease. Entries in the dispensary record books often listed only an initial complaint, so a diagnosis of syphilis might be given at a subsequent visit when the symptoms became more pronounced, as had happened with Mr. Smith. And of course, it was well understood then as now that syphilis mimicked other conditions, and until the laboratory tests became available, diagnosis was done by physical examination, symptom reports, and patient accounts of prior infections. Now, in some cases, I made some educated guesses as to who to include in my syphilis cases. For example, at the HUP dispensary, Mrs. Backman, a 35-year-old married woman, received a diagnosis of neuralgia, but the notes about her painful joints, red rash on her face, both of which were symptoms of syphilis, as well as the fact that her husband was in the hospital being treated for tertiary syphilis, led me to include her case in my analysis. Now, varying medical complaints drove patients to all 7 of the HUP dispensaries, which meant that in the late 19th century, all medical specialists became familiar with particular presentations of the disease, even if it was a small part of their practice. Patients with primary and secondary syphilis went to the venereal and genitourinary diseases dispensary at HUP. Others went to maybe the nose and throat diseases clinic, or the skin diseases clinic, or the eye diseases clinic, or the surgical clinic, depending on the presentation. Next slide. For the most part, patients with late-stage disease went to the neurology dispensary. And very often patients from all the dispensaries were referred over to the eye clinic. And Dr. DeSchweinitz practiced at a lot of institutions there and was kind of a well-known ophthalmologist making the diagnoses. Syphilis did cause a large proportion of vision loss. It wasn't always measured, but one Ohio charity said that 25% of blindness resulted from syphilis, equally divided between congenital and acquired cases. Now, with no effective treatment for eye problems from syphilis, most of the charity work would, of course, focus on preventing a neonatal gonorrheal ophthalmia. Now, back then, as today, patients sometimes delayed seeking help. Sometimes they recounted coping with severe symptoms for weeks or months before seeking medical attention. Mr. Finch, a 41-year-old married telegraph operator, was out of work for 7 or 8 months prior to his visit, as he experienced nervousness, a stopped-up feeling in his head, and slight catarrhal symptoms. And yes, he'd had a bubo 5 years earlier. At the dispensary, he received a prescription for potassium iodide and reported on his next visit that he felt better. Like Mr. Finch, Mr. Peters, a 34-year-old married Afro-Caribbean laborer, also reported nervousness, an inability to work, and a prior syphilis infection. He too received potassium iodide as well as potassium bromide, a sedative, on a second visit. As these two cases suggest, there appeared to be no observable racial differences in prescribing practices, although the data is too limited for a thorough comparison. Doctors appeared to just follow kind of a standard treatment protocol. They started patients on potassium iodide in increasing doses, then mercury if needed, and then sometimes added drugs for pain or to help with sleep or weakness. Next slide. There were 136, I hope I got my math right here, I don't always do that, dispensary patients in the records. They were not very diverse in terms of race or gender. Black men, as you see, accounted for only 7 of the cases. That was in line with their low numbers in the population of Philadelphia before the Great Migration. There were 11 women in the records, all of them white. There were a number of immigrants in the records, and they were a substantial source of patients. 31 immigrants overall, 21 from Ireland. Now, I don't know if patients received disparate interactions with the doctors because of their race, origins, or gender. Clearly, the physicians had the power in those encounters to diagnose or misdiagnose, to prescribe, to withhold, or provide information about the course of the disease. But there were always 2 people in a clinical encounter, and the patients, through their actions or simply because of their characteristics, helped to shape its meaning and its outcome. What stands out to me in these records and those from the IND is the frequency with which returning patients reported feeling better. The treatments we know did nothing to stop the course of the disease and often resulted in some tough side effects. So were the upbeat reports provoked by the attention they received or the power of what we now call the placebo effect? I don't know. Now, most HUP patients made less than 4 visits, and half of them came only once. At the other end of the continuum were people who made more than 10 visits, and in a few cases, more than 20. Next slide, I'm sorry. This latter group typically included patients who returned for twice-weekly sessions with electric currents to relieve pain and stimulate muscles. Over a 4-month period, for example, Mr. Brick, a 44-year-old, largely bedridden German immigrant cabinet maker, received 11 faradic or alternating current treatments, followed by 5 galvanic direct current treatments. Now, I will say the doctors prescribed electric current for a variety of conditions, and people could purchase devices for home use. Despite the stigma of infection, a little over 50% of the male patients at HUP admitted a chancre or a prior gonorrhea infection, sometimes appearing to confuse the two. More people may have acknowledged an earlier case because some of the records are from returning patients, and it's unclear what they reported on their initial visit. Given the patient demographics and the number of men admitting an infection, I think it's worth considering whether working class men viewed venereal disease as less stigmatizing than their middle class and upper class counterparts who had more exposure to the moral discourse on sexuality, social hygiene, and disease. I should add that doctors rarely, if ever, asked women patients about a possible infection. Were they reluctant to do so because they didn't want to utter what were then taboo words, or because clinicians believed that women had unknowingly acquired what they called a conjugal infection, and they didn't want to raise a private and presumably disruptive family matter? I'm not clear on that yet. Now, one reason for disclosing a prior infection may have been that in its earlier stages, as we know, syphilis caused relatively little trouble compared to other illnesses, and particularly the workplace and battlefield injuries that these patients reported. Mr. Wells, a 52-year-old married superintendent of mines, received 5 wounds during his Civil War service. Perhaps he believed the chancre he had in 1861 was the least of his troubles. In January of 1880, he arrived at the neurology dispensary, and there he described his current difficulties. He'd had a rapid decline in weight and strength, from 240 pounds and being, quote, one of the strongest men in the country, and, quote, able to lift 750 pounds of dead weight of iron, to becoming a weak 153-pound man. One day, he explained to the doctor, he had a chill, then a fever. He took a mustard bath, but he could not return to work for a time. Then he noticed a strange feeling in his toes, followed by a weakening in his legs, and then symptoms throughout his body. His account happens to appear in a record book of cases of paralysis over 15 years. Dr. Wood would eventually admit him to the hospital and lecture on his case to students. Wood recommended treating Mr. Wells with mercury, quote, until mercurialization, and then administering potassium iodide. Now, Mr. Wells's medical experience resembles many others, but it's the rich detail in his record that gives us a sense of his life before and after the disease was fully manifest. He was once a soldier and a strong man. He was the father of 8, a worker, and from, quote, a healthy, long-lived family. As a disability historian argues, wartime drew lines between those who became disabled valiantly and those who were unable to claim the status of hero. Mr. Wells may have slipped from one category to the other once he received his diagnosis. So how should we see Mr. Wells? From a medical perspective, he had syphilis, a pathological condition. From a disability perspective, he had impairments that restructured his life. He became unable to work and support his family in an era when physical prowess, economic self-sufficiency, and productive labor equated with manhood. He could not fulfill his role in an economy centered on industrial capitalism. Next slide. Working men in their 20s, 30s, and 40s comprise the vast majority of the patients. Most of them lived in Philadelphia and toiled in lower or lower middle class occupations. The most common one was laborer. Others worked in construction as bricklayers, carpenters, and stonemasons. Perhaps they built the institutions where they later sought care. One sign of their economic instability can be seen in the delusions that a few of them experienced when their disease progressed to paresis. Mr. Burns, a 37-year-old clerk, imagined that someone had given him $25, a huge sum at a time when the average wage in 1880 amounted to $347 a year. Mr. Washburn, a 37-year-old bookkeeper who was eventually hospitalized, reportedly told his son, quote, he need not work anymore. So a life without money and without hard labor was what I call an oxymoronic rational delusion. Now, patients, I believe, correctly perceive the workplace as the site most threatening to their health and livelihoods. Their years of hard labor and workplace exposures sometimes resulted in physical impairments that challenged the doctor's diagnostic abilities. They offered accounts of sunstroke from outdoor work, fatigue from physically demanding jobs, illnesses from hazardous exposure. The only one that was easy to diagnose was, of course, lead poisoning with the blue line on the gums. But in one instance, for example, a doctor had to consider whether a stonecutter's paralyzed arm came from his reported use of a heavy hammer or a syphilis infection 20 years earlier. Mr. Todd, a 30-year-old varnisher, was given a diagnosis of toxic tremor after he disclosed rubbing turpentine on wood for 6 weeks in a closed room. He also reported a history of daily drinking that had ceased 7 months earlier, as well as a syphilis infection 13 years prior. Which or how many of those factors accounted for his numbness, trembling, and nervous spells? Mr. Matthews, a 24-year-old laborer with a history of syphilis, complained of a headache and experienced mania and incoherence. He reported being well until 3 years earlier when a crowbar fell 7 feet and struck him on the head. Was it the bacteria or the concussion that was the source of his difficulties? His chart said meningitis. Ultimately, the diagnosis did not matter because reversing the damage was not possible. Next slide. Over 30 years after Miss Smith went to HUP, Mr. Jones arrived at the IND. Now, historians regard the Philadelphia Orthopedic Hospital as the first neurology hospital in the United States. Its medical staff consisted of elite neurologists who made major contributions to the discipline, in part through the work they did, the research they did on their patients. The hospital opened in 1867 to treat bodily deformities, and clinicians operated on so-called crippled children as well as adults suffering from, quote, hunchback, hip disease, clubfoot, knock knees. In 1870, it added the infirmary for nervous diseases, an outpatient area that soon became the primary site of delivering care. From 1909 to 1915, over 156,000 patients came to the two clinics, one for neurology, which saw the most patients, and one for orthopedic cases. The tertiary syphilis patients comprised a small but consistent part of the nervous clinic caseload. There is a set of locomotor ataxia casebooks. They contain 275 patient records from 1876 through 1917, which I will be talking about. I will add that there are 64 additional cases of syphilis in some of the other books. For instance, syphilitic epilepsy in the epilepsy volume, syphilitic chorea in the chorea volumes. Next slide. According to its bylaws, the POH served patients irrespective of creed or color, but the overwhelming majority of patients, as you see here, were, like Mr. Jones, white and working class. Casebook descriptions of individuals referred to them by race, colored or white, by ethnicity, for example, Hebrew, or by country of birth or nativity, such as US, Italy, or Welsh. And these are the records from the locomotor ataxia book. Next slide. Racist and sexist biases, supposedly grounded in science, of course, suffuse medical practice and beliefs then, as are sadly apparent now. And this was the case for the IND physicians. Charles Burr, a eugenicist, believed locomotor ataxia, also Parkinson's disease, was, quote, a rare disease among Negroes, although he did call for more research. He and the other doctors made notes on mixed race individuals with locomotor ataxia, always asking if they had any, quote, white blood. So the record of a 40-year-old widowed housewife contained the observation she was not a full-blooded negress. While racial thinking did not appear to determine prescribing practices, presumably because there were so few remedies to be offered, it shaped how clinicians thought about disease and patients and about the questions they posed and attempted to answer. Now, as we know, the search for racial differences in syphilis would become even deadlier in later decades when effective treatment was withheld from men enrolled in the Tuskegee, what I call the Tuskegee non-study. Mr. Jones's medical record begins with his primary complaint, quote, having a little difficulty walking, His visits to the IND would continue for 11 and a half years. While he differed little in terms of his demographics from the other men seeking care, his persistence proved notable, and he was not the most persistent. Next slide. As a microhistory, this is just Eswer Mitchell with the patients in the clinic. As a microhistory, Mr. Jones's record reveals the many elements of the clinical encounter that rarely appear in the historical literature. He reports his emotions, his reactions to treatments, and the details of his work life. Other aspects of his experience are, of course, absent, as was true for the others. Were they fearful or desperate when they came to the dispensary? Were they grateful, angry, frustrated, or confused by the care they received? How long did the visits last? Did the patients find the detailed questioning by the assistant physicians intimidating or a sign that they were getting proper care? Did the patients think that their race, background, sex, or religion shaped their treatment? How did they view themselves? As disabled, perhaps permanently, or as diseased and awaiting a cure? Why did some come only once and others for years on end? Next slide. 3 clinicians, the ones at the top here, saw the majority of patients, the vast majority: Morris J. Lewis, Silas Weir Mitchell, and Wharton Sinkler. If you're a neurologist, you may recognize some of the other names. J.K. Mitchell was the son of S.W. Mitchell. Mr. Jones happened to meet with Dr. Lewis, who was what I call the professional offspring of 2 esteemed parents. He began his career at the IND as an assistant physician to S. Weir Mitchell, known among other things as the father of American neurology. And Lewis then served as assistant to William Osler, known as the father of American medicine, before succeeding Osler as chief of the IND. Next slide. Mr. Jones, this is just a sample of the case book with the place where they took their notes. Like all the dispensary patients, had an initial examination from an attending physician who recorded his findings on a printed form. The patient's medical history, prior venereal infections, presenting complaints. Men were asked about alcohol and tobacco. Women were asked about coffee and tea drinking. And of course, the results of a physical examination. Additional information included age, occupation, marital status, family medical history. And patients were often asked what they believed to be the source of their complaint. And they gave some, I'll say, fascinating attributions. One man attributed his motor problems to bicycling, although he reported 4 or 5 cases of gonorrhea and a sore mouth 22 years earlier. Another man blamed his difficulties on a removal of a corn 3 years earlier. So like patients at HUP, IND patients sometimes confuse gonorrhea and syphilis, but really what mattered to them was not the source of their ailment, but their physical limitations in obtaining a cure. Now, it took very little clinical acumen for Dr. Lewis to deduce the cause of Mr. Jones's troubles, because he had the classic Tibetic symptoms, as they were then called: paroxysmal pain, an absent knee jerk, bladder problems, Argyll-Robertson pupil. Married patients were often asked about miscarriage, another possible indication of infection, or multiple miscarriages. Unlike patients who admitted the loss of their, quote, sexual power, a frequent result of syphilis infections that damaged the spinal cord, Mr. Jones claimed his was intact. While the physical examination provided Dr. Lewis with all the information he needed to make a diagnosis, he had 2 other critical pieces of information. When asked about syphilis, Mr. Smith answered 1904. He was not alone in his forthrightness. The majority of male patients at the POH, 66%, acknowledged a prior infection, typically by revealing the year of their chancre or the time elapsed since then. A second piece of diagnostic data came from the laboratory. Entered in bright red ink on his record was a report of a weekly positive Wassermann test. The ink color may have been selected to alert the physician but the red certainly made for an ironic scarlet mark on the black and white form. By the time the lab results came back, Mr. Smith had already begun taking mercury by inunction and potassium iodide. He would later receive 606 administered in the hospital as an intraspinal injection. Now, what do we know about Mr. Smith? He was the son of German immigrants, born in Philadelphia in 1878. The 1900 census showed his household included his 10-year-old brother, as well his father, and a woman described as a housekeeper and her son. It may have been a blended family because his mother died early at 47. Mr. Jones' father worked as his teamster, and he was employed at that time as a tanner, both laboring in typical working class jobs in what was then an industrial city. 10 years later, and 4 years before his first visit to the IND, the census listed him as a shipping clerk for a wholesale druggist. At that point, he no longer lived with his family, but as a boarder. He would appear in public records twice more. In 1918, when he was 40, his draft registration card documented him as having a disability in his right and left legs, not surprising given his diagnosis. Next image, please. The 1920 census listed him as a ball maker in a factory. His medical record supplied more information. He told the doctor he could stitch 42 league balls a day, and that was presumably at the Reach Baseball Factory in Philadelphia. He seems to have held that job for a few years and to have made enough money so that a medical note reported a vacation at the shore. Now, patients knew enough about venereal disease to seek treatment. A few reported taking over-the-counter medicines. Next image. One man told the doctors he had taken bioplasm, a product specifically advertised for curing ataxia, unlike the more common, quote, blood purifiers sold as syphilis cures. Some patients received prescriptions at other dispensaries or from private physicians. Mr. Jones's record quotes him as saying he'd been treated with one bottle of medicine and told he would be all right. He was not all right. Well, access to dispensary care during working hours may have been limited for men like Mr. Jones and Mr. Smith. Their drug purchases and visits to various doctors and institutions showed them as engaged consumers in a thriving and competitive medical marketplace. Next image. Missing from the medical records are the financial costs of care, including medications, often dispensed for free to those who could not afford them, and of course the cost of time lost from work. With the new technologies and treatments, new expenses appeared, and the POH began to pass along the costs to patients who could afford to pay. So they start paying $1 for a visit in 1914, with the fee abated if they lacked the means to pay. Fees were raised again in 1917, and no Wassermann tests were given without full payment. The salvarsan in particular cost money and required medical personnel to administer in the hospital. As a working man, Mr. Jones may have been able to cover the costs of his own treatment and tests. His medical odyssey included 10 Wassermanns, most of them the blood tests rather than the more painful spinal tests. Throughout his record, there are optimistic statements such as doing well and walking better. Physical signs of improvement were noted, included weight gain and the return of his sexual power, despite his initial claim. He was also... let me stop here and let me just try and sum up. He continued with the mercury, even as he took later the mercurialized serum as a treatment. He continued with the potassium iodide. He continued to have side effects. He started taking aspirin for pain, and he was not cured. 7 years after his first visit, his stance was still bad, and the doctor wrote he would fall if his feet were even a foot apart. He eventually got a negative Wassermann and then a second one Zalvarsan ended his infection, his suffering continued. In 1925, though, his record contains the observation, says he is improving, but also notes his ataxic movements and in his limbs and other extremities. Next slide. The clinical encounters at the IND followed the same protocol as at HUP, bringing together individuals with different motives. The assistant doctors came to learn neurology. The senior clinicians saw clinic duty as a moral obligation, as an opportunity to kind of get some publications out there, and to be of service to science. Dr. Mitchell, one of the few who openly voiced his opinion of patients, warned in lectures to students that they should not become hardened to, quote, the exposures and pains and suffering of the clinic and the ward, and also called his dispensary service long and tiresome, and the work, quote, an acute test of character. So why did doctors keep treating patients that they could not cure? Why did patients return? Was it the performance of authority in a culturally distinct setting? Was it the palliative remedies the doctors prescribed? Was it the attention to the patient lives? Dr. Mitchell in particular asked patients at every single visit about their appetite, sleep, and bowels, and prescribed remedies if they reported problems. Next slide. They wrote numerous prescriptions, iron tonics for weakness, laxatives and diuretics for patients whose spinal cord impairments left them with bowel and urinary problems, sleep remedies for those unable to rest, and most critically, drugs for pain, phenacetin, aspirin, cannabis indica, and on rare occasions, morphine. That too could explain why patients made many return visits and gave positive reports such as feels better. But balancing those entries, to be sure, were patients' feelings of despair, worsening pains, and growing physical challenges. Now, I want to give just a few moments to some of the non-pharmaceutical restorative treatments used at the orthopedic hospital. Mitchell prescribed electricity and massage for a number of conditions. Next image. And the hospital staff contained a medical electrotherapist and those who saw educational exercises in the hospital gym. Next slide. Let me go back one more. Sorry. And you'll see the patient hanging on the wall. That was because a lot of patients underwent suspension with various devices, like on that rack device there, to lengthen their spines and to restore, improve their mobility. Next slide. Between 1896 and 1905, Lewis, Sinkler, and Mitchell embraced a cutting-edge therapy for locomotor ataxia, brown Sicard fluid, a substance derived from testicular extracts of animals and administered by injection to the buttocks. Articles in The Lancet deemed it ineffective, but a summary of case reports in the New York Therapeutic Review cited numerous cures. The review, of course, was published by the New York Pasteur Institute and, not incidentally, sold the extracts. Now, initially skeptical of what he called testicular elixir, Mitchell, a correspondent of Brown Sicard's, used it with patients and initially concluded that whether a physical basis can reasonably be assumed, we have a fluid, a tonic of great power. At least 14 patients received it, including one white woman and one African-American man. And some of the cases he treated are described in Mitchell's book, Fat and Blood. Let me quickly add that brown Sicard fluid did not destroy the syphilis bacteria or restore damaged bodies. It did, however, have powerful, documented placebo effects. Mr. McIntosh, a 55-year-old married stonecutter, reported sleeping better, experiencing less pain, and an ability to walk just 2 weeks after being prescribed potassium iodide and 3 times a week fluid injections. He skipped them for a week, told the doctor he felt worse, and resumed treatment and then reported feeling better. Another report came from Mr. Vance, a 43-year-old married African-American barber who received injections and also took cod liver oil, mercury, and potassium iodide. Perhaps by then realizing the fluid's ineffectiveness, Mitchell wrote he regarded its effect as, quote, mental, but he nevertheless continued to prescribe the injections, noting after a year they, quote, made no difference if admitted. But he then arranged for Mr. Vance to give himself the injections, and they continued. So were the doctors engaging in patient-centered care? Were they engaging in medical experimentation? Or were they doing both? As the elites of neurology, they kept abreast of the medical literature, they contributed to it, and they did so in part by testing out treatments and publishing the results. Confronting patients with tertiary syphilis in this era, their findings amounted to learning what did not work. Now, neither Mr. Smith nor Mr. Jones recovered from the damage done to their bodies by syphilis. From the perspective of a medical historian, we can say Mr. Jones exited the category of disease because he had the 606 injections. From the perspective of a disability historian, he was permanently impaired. His medical journey illustrates, on the one hand, the extent to which physicians continued to rely on standard useless remedies along with the newer ones, and it shows, on the other hand, how little the lives of patients with tertiary syphilis changed, even when they received the newest therapy. Now, yes, some did receive therapy early on, and it was life-changing. Now, I don't know why Mr. Jones stopped coming to the IND after seeking care for over 11 and a half years. I know little about his life other than what appears in his medical record, and that's true for most of the cases. Yet, these spectral subjects, as I call them, have something to say to us. To medical historians, the remarks they make to the doctors offer lessons about understanding diagnosis and treatment from the vantage point of the patient. Their accounts offer insights into how disease shaped their family and work lives, as well as the individual challenges of coping with increasing disablement. To disability historians, these records say something else, in part asking them to explore individuals damaged by stigmatized diseases, a group they have largely ignored, except for more recent studies of HIV/AIDS patients and Tuskegee patients. The diagnosis offers a critical illustration of the synergistic effects of a stigmatized disease and its disabling consequences. And two, we have very few accounts of poor minority and working class people with syphilis. So these records suggest something what is likely true for millions of others. On the one hand, their visits will illuminate the sea change in medical diagnostics and therapeutics that would go on to save the lives of many, but not their lives. Their ongoing health struggles serve as a reminder to pay attention to people left floundering and drowning in the shoals when a cure is impossible. Next image. And I will now take questions, but first I'm going to turn on a light so I can see better. So go ahead and ask those questions, Nicole.
Thank you so much, Janet. As an archivist, I do want to say that I just greatly appreciate when somebody uses these historical records, such as the casebooks, for such a variety of purposes, from treatments, as you were saying, examining the patient-doctor relationship, demographics of patients over time. So it's really fascinating. And I also want to say thank you again for this fascinating talk, but especially for powering through it when we know you're not feeling 100% today. So we do have a few questions that have come in the chat, and everyone else, please feel free to drop your questions in. We can stay a few minutes late to answer some of these. So the first question is from Devon Jackson, who said, hello, thank you for your presentation. I would like to know if any hallmark accounts from psychiatrists involved in the treatment process that you could share or direct us to.
I will say in this period, the psychiatrists might have done service at the institution serving people with paresis and the kind of terminal stages of disease, but they don't show up in my records. So Pretty much it was syphilis was seen, it comes out of dermatology really, moves over to neurology, but it was not until you had paresis, you were not in the domain of the psychiatrists or the alienists, as they were sometimes called, who are working in institutions.
And do you know of any records that exist that might describe those treatments, the psychiatric treatments? I'm not sure of any. There must be
I have
some,
looked at the records of the Philadelphia, the Home for Incurables and some of the others. And they're basically, unlike these records, just ledgers with names of patients and a diagnosis. What's so wonderful about these records is they have a lot of commentary. And I will say I feel like I was a little too old to be reading badly handwritten patient records once again in my life, but they are fascinating.
Great, thank you. We have another question from Paula Summerly, and she asks, did Dr. Golden link any of the patient records to autopsy protocols and or pathological specimens?
Nope, they were not autopsied. And I want to remind people, especially for my immigrant patients, and many of them were Irish immigrants or Eastern European immigrants, you were not to be autopsied in this era. That's one reason, for instance, that people with late stage tuberculosis would, as they call it, elope from institutions housing them because they did not want to be autopsied. They wanted to be buried untouched in their religious burial grounds. So we don't see too much of this going on. The dispensary patient, now I did not look at the hospital patient records and if they went to autopsy, but the dispensary patient records, they would just stop coming unless they got admitted to the hospital for treatment or unless they were sent to one of the, we'll call it the palliative care end of life institutions.
Okay. And also you mentioned these ugly laws, which are incredibly fascinating to read about, that really kept people off the streets. And what resonated with me, I was thinking about the quote, broken faces in France after World War I, these sort of disfigured soldiers. When did those ugly laws change in the US? And did World War I and sort of the resulting soldiers coming back with these grievous injuries change any of that?
Yes, people, if you're an ugly beggar on the street in Chicago in 1910, they might charge you and remove you from the street. If you're a veteran and you have the markers of that, you're missing a limb or something, your face was blown off, no, you could be out there. And they were only applied in some cities, not all. It was a way of, what today we would call vagrant control or controlling often unhoused individuals, but given the unfortunate term of ugly laws.
Yeah. Okay. Thank you. And we have a question from Eric Loft, who says, Janet, would Mary Putnam Jacoby have ever seen S. Weir Mitchell as, quote, patient-centered, given how she criticized his treatment of women patients?
Yes, that's such a great question. And I for those of you who know S. Weir Mitchell, you will not be surprised to know that the majority of patients at the Institute for Nervous Diseases and at the Philadelphia Orthopedic Hospital were diagnosed with neurasthenia. And yes, S. Weir Mitchell definitely treated the women patients with bed rest. I do have some exchanges where he's checking with Halstead about whether we should remove ovaries from these patients. So no, he was, so we can I view him as somebody, after having read so many of his records, as somebody who was a terrible clinician, but as somebody who, much more than the other clinicians, paid attention to the patient's symptoms and lives. So I think he's a little more, so I think he did terrible thing to his women patients. I think he's was quite supportive of these working class, mostly men, who were struggling with probably a life-ending disease. And I'd like to see him as much more complicated. But I will say, and I will acknowledge, because thanks to the work of one of my students, of course, S. Weir Mitchell treated women and men very differently. So if you're a woman with so-called neurasthenia, you would be put on that horrible bed rest. If you were a man with neurasthenia, you would be told to take a sea cruise for 2 years, which to my mind doesn't sound so bad.
Thank you, Janet. We have another question from David Wolf, who says, excellent talk. From your research of tertiary syphilis during the 19th century, what can we learn today concerning poorly understood chronic diseases such as fibromyalgia and chronic fatigue syndrome?
Whoa, that's a very good question. What can we learn? What I learned as a person is the need to pay careful attention to combating the symptoms of things we don't understand. And I would say doctors Sinkler, Dr. Lewis, others were, I'd say, very attentive to that. I suspect that their experiences in the Civil War as clinicians treating people with all kinds of horrible injuries maybe made them attuned to stopping the suffering as well as turning people into addicts. But I really wonder today how much the quest for maybe the precise diagnosis has blinded people for the need to say, I don't know the diagnosis, I know the symptoms are bothering you, and here is where we will go. And believe me, I was quite impressed with the attention that they paid to the suffering of these patients who were never getting better, despite the many interesting attempts they had at treating them, particularly the brown Sicard fluid.
And Janet, do you know if there were private treatment centers for the wealthier patients who may not have been going to these other hospitals for treatment?
Oh yes, a lot of private patients with syphilis went to the hot springs in Arkansas for private syphilis treatment. And there's a wonderful book about that. I want to credit that. And those doctors were equally sure that their hot springs treatments and the other things were curing their patients, and their patients were getting much better. So it's just like the private facilities comparison at Saranac for the people with tuberculosis to the public hospitals for tuberculosis. Although I will say people with tuberculosis had a fair amount of charitable care and charitable work sent their way. When you have a stigmatized diagnosis, that is not the case.
Okay, well, I think we're unfortunately out of time today, Janet. I want to thank you again for this wonderful talk. Thank everyone for attending as well, and to encourage everyone to attend our next Heberden Society lecture on January 18th. I'll be sending more information out about that following tonight's talk. So thank you so much and have a wonderful evening.
Thank you.
Bye.
Bye.